Welcome to this Vattikuti Foundation Masterclass in collaboration with the International Continence Society. I'm Dave Meinhardt in Detroit with the Vattikuti Foundation, and I'd like to introduce the CEO of the Vattikuti Foundation, Dr. Mahendra Bhandari, who will be welcoming you to this program today. Thank you so much for joining us.
Thank you, Dave. At the outset, I welcome people from different parts of the world because every time we have an international registration. And I would like to mention more about the Philippines, which really tops in order of frequency in the countries who participate in our webinars. I really thank Sanjay for putting it together. Of late, we were very, very happy to collaborate with international societies who have the essence of essence. Last webinar, some of you might have heard, was with the BCG group. And really, it was a treat to watch. It's a totally different plane of discussion. Very simple, yet drilling deep into the subject. Today, we are looking forward to a fascinating discourse by three experts. Thank you, Dr. Rizwan Hamid and Dr. Enrico for sparing your valuable time for us. Vattikuti Foundation looks for the spaces which are unfilled to take the education as a medium for improving the patient care. And neurogenic bladder is one such thing. I claim as no expert on the subject, but I am an ardent student of this, though my specialty was not. I've been flipping from one to another. I used to call it pivot from one to another. Why this subject is dear to me, this historical context would be very important. In 60s and 70s, perhaps, when I was a generation of students in late 60s, the concept of neurogenic bladder was restricted to paraplegic bladder. And what we would be talking about is spinal cord injuries and spina bifida. Spina bifida was being taken as a curse, like we have Down syndrome and other anomalies. And it was being taken as non-compatible with the life. We did not have any understanding of ambulatory patients having neurogenic dysfunction. My own dissertation in 70s in Masters of Surgery was on 25 cases of paraplegic bladder, which I was uncomfortable while reading the subject. I changed it to spinal urinary tract dysfunction in spinal cord injuries. In this dissertation, there was no urodynamic concept of the bladder. Only from Long Beach, California, Paraplegic Center, Estin Kumar and Ernst Borst had a lot of work on cystometry. I made a Marshall cystomanometer to study the pressure. And I created a sphinctometer by a aseptic syringe to see the outlet resistance in 25 patients. I didn't understand anything from that point of view. This was the historical context, but now you see how finely whether we are able to understand what exactly happens real time in a patient while he's voiding. Still, a lot of factors remain to be addressed. And in my own practice, extending over 4 to 5 decades, I would like these panelists to address the issue of fatigue, patient and for the families. Because you look at spinal cord, spina bifida patients since birth, we are looking from cradle to grave kind of care. And urinary tract is the one which needs a dynamic management by a specialist because the patterns keep on changing. And every time our focus is on kidneys because that is what is going to stay. Thank you once again for helping Foundation. And this is, I hope, not the first and the last interaction we have in International Continence Society. Thank you.
Thank you so much, Professor Bhandari, for your words and for introducing the program. So let me straight come to the program. And the program this today is on the identification and the treatment of high-risk neurogenic bladder. And specifically, we are going to examine the issue of safety of neurogenic bladder in terms of kidney disease, and whether we are really at a point in patient care where the global urological community can consider a goal of eliminating preventable kidney disease. This is a joint program of the Vattikuti Foundation and the ICS. And as I said, high risk varies globally. So secondary kidney disease, in fact, works like a double disaster. So somebody who had a spinal cord injury or a spina bifida now faces a double disaster of a kidney disease, which was essentially preventable. And this global problem, it affects all countries, but perhaps the brunt is borne more so by the developing world. But the spectrum varies. So the kind of disease processes we get in different parts of the world is different, and you will come across this in the remaining part of our discussion. But we must regard this as preventable and perhaps as a measure of the quality of urological care that we are able to deliver. So what are the learning objectives for today's session? We would like you to be able to understand what are the conditions or the features that confer a high risk status on neurogenic bladder. What is the critical importance of storage function in determining safety? The need for combining clinical evaluation, ultrasound scans, creatinine, urodynamic, CIC diary records in patient care, as well as their limitations and caveats, and the recognition of red flags in patient care. So I think if we are able to achieve these four objectives in terms of patient care, I think we would have achieved what we would like to from today's session. For this, I have got faculty from across the globe for you, literally. We've got Dr. Rizwan Hamid, who's a consultant urologist and honorary senior lecturer at the University College London in UK. He's the clinical lead for neurourology at the London Spinal Injuries Unit. He's also a member of the Urology Guidelines Committee panel for the European Association of Urology Guidelines and director of the ICS School of Neurourology. Hi Rizwan, welcome to the program. We've got Dr. Enrico Finazzi. Dr. Enrico Finazzi is from the University of Rome. He's a professor of urology. He's a past president of the Italian Society of Urodynamics. He's also a trustee of the International Continence Society. These are very brief introductions for our faculty who have very illustrious careers. And of course, myself from Hyderabad, Apollo Hospitals in Hyderabad in India. We have with us also Dr. Mahendra Bhandari. And Dr. Mahendra Bhandari is perhaps the only person I know who has his own Wikipedia page. He is somebody who is a global figure. I will not go into the details of who he was, except to say that he was my faculty, he was my mentor, and has been a deeply inspirational figure for me through my life. He has touched the lives of innumerable number of urologists across the world, both initially as a faculty at SGPGIS and PGIMS in Lucknow, as well as later through the Vattikuti Foundation and his work with the robotic urology, or robotic surgery. This is a very old photograph, Professor Bhandari might remember, from 1992. And just for some of you who are not aware, that in the middle is Professor Bhandari sitting at the end of one of these annual programs where we would see off some of our seniors. This slide actually incorporates a whole lot of famous people from across the globe. Dr. Anant Kumar, who just was the president of the Urological Society of India. Dr. Ashutosh Tiwari, a global figure in robotic prostatectomy, currently based in the US. Dr. Rakesh Kapoor, who was director of the Sanjay Gandhi Institute and is now at Medanta at Medicity. Dr. Rajesh Ehlawat, who's not in the figure, another faculty of mine who has done pioneering work on robotic transplantation. He's the internationally acclaimed pioneer for robotic transplantation. and Dr. Anish Srivastava, again in absentia here, a professor and head of department at the Sanjay Gandhi Institute. So really, it has been a pleasure working with Dr. Bhandari. I really find him deeply inspirational in my life, and I thank him for all that I am today. The masterclass agenda today consists of three lectures, and these are first by Dr. Enrico on what constitutes high-risk neurogenic bladder. That will be followed by a first world perspective by Rizwan on eliminating kidney disease secondary to neurogenic bladder, the first world perspective. Then a talk by me on eliminating kidney disease, secondary kidney disease, the developing world perspective. And then we will have a set of discussions which will include a whole range of issues, and I hope some questions and comments from you, the audience. So please feel free to send in your questions or comments, because we will eagerly look forward to discussing them as far as we can. And then at the end, Dr. Rizwan and Dr. Enrico will give you some details about the ICS and its initiatives before Professor Bhandari closes the session. So I will stop my screen sharing at this point and invite Enrico to start his talk on what constitutes high-risk neurogenic bladder. Enrico, please, welcome to the program.
Thank you, Sanjay. First of all, let me say that it's a real pleasure and honor to be here with you today, invited by the Vattikuti Foundation. I would like to thank for that Professor Bhandari for the kind invitation. It's an honor also to represent here the International Continence Society. The International Continence Society is the leading society in the research and education on continence. So it's really one of the most important society, or probably the most important society also in the investigation and treatment of the neurogenic bladder. So I would like to start, first of all, showing, if I'm able to, showing my disclosures, actually nothing particularly related to this topic. And I would like to start with the definitions. Now we usually prefer to talk about neurogenic lower urinary tract dysfunctions instead of using the term neurogenic bladder. And neurogenic lower urinary tract dysfunctions are defined as lower urinary tract dysfunction secondary to a confirmed clinical relevant neurologic disorder. And as I was saying, probably it's better to talk about dysfunctions in terms of instead of a neurogenic bladder, because we are looking at different situations, different clinical aspects, clinical conditions that are different in terms of investigations needed and treatment and prognosis. So we see, I mean, very different patients with the same definition of neurogenic lower urinary tract dysfunctions. We see cerebrovascular accidents patients, so stroke patients actually, patients with dementia, patients with Parkinson's disease, patients with brain tumors, patients with spina bifida, or patients with spinal cord injuries. All these patients have some specificities and are different one from each other. The major guidelines agree on one point. The first aspect to be considered in these patients is to preserve the upper urinary tract. These are the statements of the guidelines of the European Association of Urology. If you see in the first line, the first concept that is underlined by these guidelines is that we have to protect the upper urinary tract. And if you look to the also the suggested about surveillance in neurogenic lower urinary tract dysfunction patients, we have to make a special surveillance in high-risk patients. We have to use a laboratory and diagnostic tools, and especially the urodynamic investigations, to investigate these patients. But what does high-risk patients mean, actually? What is the definition for high-risk patients? First of all, there are some of these patients that are more at risk than others. Actually, we know from literature, I've cited here two very important review articles, and both these articles agree in defining as high risk patients with spina bifida or patients with spinal cord injury. They have a higher risk to develop complications of the upper urinary tract in comparison, for instance, to multiple sclerosis patients that may also have complications of the upper urinary tract, but in a lower amount of cases. And we know that closer surveillance and early intervention may decrease and has decreased, in fact, morbidity and mortality related to urologic causes in these patients. So we have to understand which are the patients at risk, and we have to follow them carefully to avoid complications, morbidity and also mortality. How should we investigate and how should we follow them up? The concept that is usually agreed upon is that we have to keep the trousseau pressure low, both during the filling phase and during the voiding phase in these patients. We have to have a low pressure in the bladder, low intravesical pressure during the filling and the voiding phase. How we can study, how we can investigate these patients? The urodynamic studies are the only method to evaluate the pressure in the lower urinary tract during storage and emptying. So we have to study and to investigate these patients with urodynamic studies. But what is the limit of pressure that can be considered dangerous? We have all learned from this study by the group of McGuire. It's a very historical study published more than 30 years ago, that 40 centimeters of water may be considered a level of risk. So let's say a cutoff value to determine patients at risk or not. Let's say above 40 centimeters of water, patients are at risk, and below 40 centimeters of water, they are not at risk. But still, there is no agreement on this limit, because there are uncertainties, and some other authors consider 20 centimeters of water as let's say, a safety value for dividing patient at risk or not at risk, whilst others consider 40 centimeters of water. But actually, there is no agreement. Let's say that the lower is the pressure, the better is the condition of the patient. Some confusion may also derive from the fact that the paper by McGuire and other papers have considered the so-called detrusor leak point pressure. That is the pressure when you find a leakage, a urine leakage in the patient, but without any contraction of the bladder. So only due to, let's say, a reduction in compliance of the bladder. So no activity of the detrusor should be present to define a detrusor leak point pressure. If we want to consider the activity of the detrusor, we should use this new term that was proposed by Tufan Tarjan and other authors, and that is now comprised in the terminology of the ICS, that is neurogenic detrusor overactivity leak point pressure. That is the leakage during an episode of neurogenic detrusor overactivity. So it's the level of pressure that is needed during an episode of NDO to provoke leakage of urine. So again, two different concepts. The detrusor leak point pressure is for a reduced compliance. Neurogenic detrusor overactivity leak point pressure is for neurogenic detrusor overactivity. So sometimes some confusion may be done between these two different conditions, and it is not said that what is true for the DLPP is true also for the NDO DLPP. So we try to investigate this aspect in some of our patients, and curiously we found that 40 centimeters of water, 40 centimeters of water was a good cutoff value also for the NDO-LPP, because patients with a pressure above 40 centimeters of water in our case series had a threefold higher risk of vesicoureteral reflux in comparison to patients with NDO-LPP below 40 centimeters of water. So it was 28% risk in the group above 40 centimeters and 9% in the group below. Of course, some patients had reflux also with the pressure below this limit. But coming back to general concept, so the reduced compliance and high DLPP are the major risk factors for upper urinary tract dysfunction, and the role of urodynamics is mandatory in these patients. But we need a better implementation of assessments in the daily practice, also because we cannot use the same follow-up or the same studies in all patients. We need guidelines specific for every set of patients. So the ICS has started to produce some let's say, best practice papers to try to help all the people who are involved in the management of these patients. And this is a paper we published with a group of experts in the ICS on spinal cord injury patients. We try to give some suggestions on how and when to perform urodynamic investigations at the beginning of the just after the injury, just after the spinal shock phase, and then in the follow-up of these patients. And I mean, you see in this slide that we recommended, let's say, some periods for the follow-up in the different conditions. But of course, the level of evidence for these recommendations is not that high, because we miss clear evidence from the literature. So many of our recommendations are based on expert opinion, because I mean, we don't have this much of evidence to suggest a perfect timing in these patients. But we know, on the other hand, that this is a paper from the Center of Zurich, from the group of Thomas Kessler, that the patients, if they are regularly followed up, the risk of visceral renal reflux and other complications of the upper urinary tract is generally rare and of low grade. So if we follow up regularly and carefully our patients, we may prevent the complications for the upper urinary tract. This is a study with 70-year follow-up. So I mean, I think it's very important study to show the relevance of the follow-up to prevent problems for the upper urinary tract. Other risk factors, are there other risk factors? Yes, of course, not only urodynamics, also the predictors of upper urinary tract deterioration, maybe the use of a chronic indwelling catheter or a suprapubic catheterization, according to this Chinese study. And according to this study of a group of experts from Germany, in case of recurrent urinary tract infection, especially if febrile, in case of increased PVR, post-void residual urine, in case of hypotensive or hypertensive crisis related to autonomous dysreflexia, in case of incontinence or voiding problems, in presence of hydronephrosis, or with persistent abnormal laboratory findings. These are all risk factors for deterioration of the upper urinary tract. So to go into the conclusions, we have to identify these patients at risk. And we know that patients at risk are basically the spinal cord injury patients and patients with myelomeningocele or spina bifida. These are the patients more at risk for that. The role of urodynamics is very important, but we still don't know how low we should keep the intravesical pressure. We know that let's say that the lower the better, but we don't know exactly the the cutoff for the safety of the lower urinary tract and the upper urinary tract. And then we have to consider other risk factors. We have to consider that the surveillance program must be different for different urological conditions and should take into account the specificities of the single patient, disability, social-cultural and economic condition, and other specific risk factors. Sanjay, with this I have finished, and I give you again, the podium to you.
Thank you so much, Enrico. So keep your questions ready. We will discuss all the questions as far as possible during our panel. I will now request Dr. Rizwan to step in with his presentation on the first world perspective on preventing secondary kidney disease in patients with neurogenic bladder. Rizwan.
Sanjay, thank you very much for the kind introduction. And I would like to echo Enrico's words in thanking Professor Bhandari and the Vattikuti Foundation for involving ICS in this webinar. It was fascinating to actually hear Professor Bhandari's experience with neurourology 30, 40 years ago. I would say, unfortunately, we haven't made that much progress, and neurourology is still the stepchild of urology, where the robotics and stones and all the fancy things with the lasers take precedence. But he was spot on in saying that one of the fascinating things of those of you who like to be involved in neurourology is these are your patients for life, and you literally cradle to grave, and we are going to discuss spinal cord injury. They are with you for the long haul, shall we say. So my remit was to talk about the eliminating kidney disease, which is very much what we are talking about, that they are patients for life. So once they get a spinal cord injury, what is going to happen over the long term? And I've been asked to talk about the first world perspective. So these are my disclosures. What I've tried to do is to divide my talk into these kind of subheadings. What is the normal? We need to know what the normal is if you want to talk about what the abnormality is. A very brief few slides about the pathophysiology, and I'll restrict myself to the spinal cord injury. Then what are the treatment guidelines? And I put the recommended protocols within inverted commas because that is the thrust of my talk. What is happening in the first world? These terms are sometimes difficult to see politically. What is the first world? What is the developing world? Rich countries, poor countries. But broadly speaking, I think all of us know what we are talking about. And then there's a last summary slide. So I'll take about 12 odd minutes to go through my presentation. So what is normal? When the bladder is empty, the storage phase starts. There's a sensation to void, which we can suppress. There's no activity. And then there is a voiding phase. But herein lies the issue that 98% of the cycle is in the filling phase. And I can't emphasize enough that this is what all neurourology is about. All of us practice urology, in general urology, in non-neurogenic patients. We know, especially in men, that they've got long-standing voiding dysfunction, but they only come to us when they have got storage symptoms. It's the frequency, the urgency, getting wet at night, which bothers them. And same in the IPSS score, that are the bothersome symptoms where they mark themselves very high. The thrust of neurourology is in the filling phase because, like Enrico showed very well, it is that 40 centimeters of water pressure beyond which the kidneys cannot drain and the upper tracts are at risk. So the whole of neurourology is to make sure that the filling phase, the 98% of the cycle, the pressures are lower. That's the anticholinergics, the Botox, the cystoplasties come into effect. Voiding, short period of time when the pressures are high, like it happens in sacral nerve, sacral anterior root stimulator, it's not that big a problem. So remember, it's the storage phase which we are concerned about. Restricting ourselves to the spinal cord injury, what happens in an infrasacral, and I'm sure all of us are aware that the spinal cord ends at the level, the bony level T12L1. So anything below that level will become an infrasacral lesion, like an injury to the L4, L5 spinal cord injury, or same as a quad equine. The same thing happens, but everything becomes flaccid. That is, the bladder becomes flaccid so that it can hold on a lot of urine, sometimes up to a liter, and the sphincters are also weak. For a neurourologist, it is not a concerning situation if I loosely use that term because the low pressure will let the kidneys drain and the patients will be incontinent, will have incomplete emptying, urinary tract infections, but upper tracts are generally not at risk. So here, very rarely we're going to say somebody who's going to have kidney failure unless they get lots of urinary tract infections, which is very, very unusual. But the whole of urology revolves around the suprasacral region. This is what we are concerned about. And probably it will not be an understatement to say that this is what we are all concerned about. That is the lesion between the pontine maturation center and the sacral maturation center. If this is disrupted, what happens? Pontine maturation center is responsible for the reciprocal innervation, i.e., it tells the bladder to relax and sphincter to contract during the filling phase. And then once it is socially acceptable to void, that's all what the higher centers do. They don't do anything else apart from removing the inhibition so we can void naturally. And at that time, the pontine maturation center will take over and is responsible for synergy, i.e. to make sure that when the bladder contracts, the sphincter relaxes. And when this is knocked off in a suprasacral spinal cord injury, then we get the detrusor sphincter dyssynergia. The pressure, which Enrico said, goes up. The bladder becomes tuberculated, high pressure, kidneys can't drain, and we'll have some video dynamic tracing to see what happens at that level. So this is what we are concerned about. This is a urodynamic trace, very classical urodynamics. I think urodynamics, once those of us who are interested, and those of us who would like to learn, it's a pattern recognition. You know, we know when there's a structure pattern, just like in CT scan and MRIs of the kidneys or the prostates are. So here, it's a classical sawtooth appearance of neurogenic detrusor activity. And you can see it goes on and on for more than 5-10 minutes. This is what happens when there's a sphincter dyssynergia, blown up prostatic fossa. You can see the bladder is not at the moment tuberculated. There are some tuberculations, but this is what we are worried about. This is what concerns us when it happens over a long period of time. And this is what Enrico was talking about. There's a Maguire 40 centimeters of water pressure. If it goes on and on and on, this is where the upper tracts become at risk, because if the bladder is more than 40 centimeters of pressure, the kidneys cannot drain. It leads to bilateral hydronephrosis. And this is what we are concerned about. We'll come back again. So small capacity bladder, reflux, and goes up into the kidneys. And we are going to, I'm sure, going to debate that once we do the urodynamics in neurogenic patients, should it be standard urodynamics, i.e. without video or with video? And I always make it a point here that had this patient had urodynamics non-video, we would have filled it up. The fluid would easily could have gone into the upper tracts, and the tracing would appear as a bladder which is low compliance because upper tracts are now taking the brunt, can hold 500 mils and stable. But this is what we want to avoid. This is all neurourology is about. So it's very important to know. And again, I'm sure we're going to discuss in discussion, we need to know what the urodynamic question is. Neurogenic patients or non-neurogenic patients? And that is very important. So coming to the my talk of first world versus the developing and developed world, this is what we used to see. The mortality of renal complications, urological complications, World War I, anybody who's got a spinal cord injury dies of renal failure, renal complications, probably 85–90%. By the time it was a Vietnam War, it was much less, and now it is even less in the developed world or the first world, whatever you want to call it, because we have been very proactive in identifying and then treating the complications. And this is what my talk is about. And I'm sure Sanjay is going to show the other side of the coin. How we have managed it, there's a plethora of information out there, which is the way is good, that every society has come up with guidelines. Broadly, they all agree with each other. There are some differences which we can discuss, but the EAU, the ICI, the ICS, AUA, SUFU, and this NICE is from the United Kingdom, which is National Institute of Health and Clinical Excellence, which not only gives guidelines from clinical, but also from the economic point of view. So what is the aim of the treatment? And EAU guidelines very succinctly summarize this. We want to restore the function of the lower urinary tract, try to achieve continence, but we want to protect the upper tract. This is what physicians want to do. But the patient who's got a suprasacral spinal cord injury, generally a young man in his 20s, doesn't care about the upper tracts. He wants to have a good quality of life. He wants to pee naturally. He wants to have good erections. He wants to have sex, wants to go with his mates to the pub and drink to death. He doesn't want to have to catheterize or put a catheter in. And it's the balance between what the physicians feel now and later on, because now the life expectancy should be the norm. There are differences between paraplegics and quadriplegics, and also somebody who's got a high spinal cord injury or a multiple sclerosis patient will have different aspirations and different life expectancy as compared to somebody who's got a infrasacral spinal cord injury, self-catheterizing. So the neurological diseases, like Enrico very rightly pointed out, MS and spinal cord injury are different. So the aims of treatment for the progressive disease will be different from a disease like spinal cord injury, which is stable. But overall, the principles are the same: to protect the upper tract, maintain continence, and improve the quality of life. So that background, what are the treatment protocols? And like I said, everybody, all the international organizations have come up with guidelines. I quite like these. These are from the ICI, and they very succinctly divide into there's a buff bond in the suprasacral and the peripheral nerves, the history and assessment. But this is for the initial assessment, like then non-surgical. So behavioral modifications, for overactivity, intermittent catheterizations without medications, or the other modalities like pads and devices. Very simple, very straightforward, identifying what the problem is the bladder is overactive or underactive, and treating it accordingly. But then, like I said, that all catheters are not the same, and all types of bladder management is not the same. And here we can see the comparison between the intermittent catheters on one hand and urethral catheters and suprapubic catheters on the other. And you can see that the complications with the urethral catheter and suprapubic catheter are a lot compared to the gold standard, which is the intermittent catheterization, which is not written here self, and I've omitted, and we hopefully should go into the, once we have the debate about the hydrophilic catheters, single use, multiple use, because that's very important of what we are discussing today. Stones are also more, and so is the reflux. So that is why most of the guidelines agree that the intermittent catheterization is the gold standard when somebody cannot empty their bladder, be it overactive in a suprasacral spinal cord injury with sphincter dyssynergia, or underactive in an infrasacral spinal cord injury. Generally, size 12 to 14 is used. One needs to catheterize 4 to 6 times a day. And this is important, that the pressure should be below, the volume drain should be below 400 mils, because there is evidence that if you distend it beyond that, there's an increased risk of infection. And the suprapubic catheter should be used judiciously. The SIUD guidelines say the same thing, that patients should consider spontaneous voiding or intermittent catheterization as the patient are stable. Any irreversible surgical interventions should be delayed for a year. The mainstay is the anti-muscarinics and Botox if the overactivity is not controlled. This is related to the suprasacral, which is our topic today, where it can cause damage to the kidneys if the pressures are not brought under control. Indwelling catheters, like I showed you, or the suprapubic catheters, are a high risk of iatrogenic complications, reflux, stones formation, and intermittent catheterization is the gold standard, both in the developing and developed worlds, whether it should be a single-use catheter or the same catheter used almost for a week can be according to the local preferences. What about the investigations in the first world, shall we say? And Enrico has shown this slide also. This is very important to show that the value of urodynamics in predicting upper tract damage in neurourology, and we have published this from the ICI and the EAU, that patients with the spina bifida and spinal cord are at a high risk of developing, and that is the reason that the urodynamics, if is done proactively, can pick up these problems before the ship has sailed. So once the upper tract has been damaged, we know when the creatinine goes above normal, then the 50% of nephrons are already gone. And again, that is why a follow-up of neurological patients is dependent on the urodynamics. It is the only method which can predict and pick up the problem before actually it happens and puts pressure in the upper tract. All guidelines agree that urodynamics is available, and then, like I said, video urodynamics should be performed at least to start off with, or when there is a change, like patients start getting recurrent infection. And this is how we minimize the risk to the upper tract in the first world. AU guidelines, again, agree with the other guidelines, assess the upper tract, do the examination, perform urodynamics as a mandatory baseline investigation, and then in a high-risk patient, regular intervals. What the intervals are left open, but generally we agree is somewhere between 1 and 2 years. What about the specialized management? And again, it is from the ICI, again saying the same thing. If there's stress incontinence, all options are on the table: sphincters, slings, tapes, bulking agents. Okay. One more minute. I think I'm running out of time, so I'll just say one more minute. EAU guidelines agree with that slings for females, sphincters for males. Follow-up guidelines are very important, that long-term ultrasound scan should be done, and urodynamics should be done as part of the surveillance for high-risk patients. All other guidelines agree with the same, and that's what should be done. The patients should be regularly followed up with evaluation, upper tract ultrasound scan, and urodynamics. So in summary, the way the first world works is that the cultural and religious and the regional differences are responsible. In developing countries, the SIC are inadequately treated. Mortality rates are high among the developing worlds, but this is very important. The first 24 hours after SCI is very important. In high resource countries, now the life expectancy is more or less the same as able-bodied. The cause of death is same as general population. Unfortunately, in the developed world, that is not the case. Thank you very much. And sorry for using an extra minute.
Thank you so much, Rizwan. No, that was very good. So if you can stop sharing your slide now.
Yes, just done that. I just wanted to show the beautiful picture of my city, London.
The stage is set for me to discuss about the developing world perspective. And so let's see if we can throw some light about this. So essentially, when we are looking at these two conditions, high-risk conditions, spina bifida and spinal cord injury, there is a primary and a secondary prevention, which is really outside the purview of the urologist. Very important, but outside our purview. But what we do know is that the incidence of both these problems is high in our country. So in India, the incidence of spina bifida is 19 per 10,000 compared to the US or France, where it's about 1/3 of India. Similarly, the incidence of fatal road traffic accidents is about 150,000 in a year. That's 2019 data. And India, which accounts for 1% of the global number of vehicles, accounts for 6% of the deaths. But as I said, some of this is beyond the scope of our discussion today. So what I am really going to talk about a little bit here is on the preemptive urological management as a tertiary prevention to prevent upper tract damage in a patient who already has a setting of either spina bifida or spinal cord injury. So let's look at neurogenic bladder specifically in spina bifida, because Rizwan has discussed at length about spinal cord injury. We know that neurogenic bladder is almost universal in patients with myelomeningocele. So you can see in a study reported recently, about 97% of patients who had a myelomeningocele showed neurogenic bladder features. So very, very common, almost universal. Renal dysfunction, on the other hand, is rare at the outset. So let's look at the Umpire study published very recently in the Journal of Urology 2019, which looked at some of these imaging evaluations. And you can see that at the outset, hydronephrosis, reflux, scarring, and a difference in split function, all of which would indicate that there is an issue in terms of single or both kidney functions, is actually quite uncommon. So much so that 94% of patients are shown to have normal renal function as defined by strict criteria at the outset. So now we've established myelomeningocele or high-risk forms of neurogenic bladder related to spina bifida, very common, but renal dysfunction at the outset, very rare. But renal dysfunction, unfortunately, is common with time. So what you can see here is that there's a drop in GFR in these patients as compared to the general population. And this here is data from the Western world. So you can see even in the first world, there is a drop in GFR, but some of this gets exacerbated in the developing world. There's also clear evidence that patients develop chronic kidney disease, and at a younger age, they require a transplantation at a younger age. And the damage to the upper tracts is almost invariably secondary to lower urinary tract abnormality. And see here the absence of VUR, the probability of absence of VUR with time. And you can see as the years progress, VUR tends to become more and more common. And we could take VUR here as a surrogate for a patient who, a new VUR, as a surrogate for a patient who's not been managed perfectly. And these are patients again from the Western world. All these patients were on CIC. And I would submit that a large number of these patients probably did not have adequate storage care, which is what Rizwan was also talking about. So just CIC is not enough in these patients. The other aspect of specifically spina bifida is that our assessment of renal function gets confounded. So creatinine clearance tends to overestimate GFR when the GFR is low. It's impacted by the height, weight, and the muscle mass, especially because these children often have poor muscle mass in the lower half of their body, and that can impact our assessment. The other aspect is that the problems with the kidney start in one kidney, and you may not pick it up unless you're doing split evaluation, and that requires imaging. What imaging? Ideally nuclear scan, but in a large part of the developing world, a nuclear scan may not be easily available. But a micturating cystourethrogram is available almost universally across the world, and ultrasound scans available universally. So you can monitor for the growth of the kidneys, development of hydronephrosis and scarring on an ultrasound scan. And most data suggest that there is a certain sequence by which the lower tract impacts the upper tract, and hydronephrosis is interposed in between. So you do not ordinarily get abnormality of the upper tract, that means renal dysfunction, without the development of hydronephrosis. You can get acute kidney injury, but you don't typically get chronic kidney disease without development of hydronephrosis. And you can see here that again, once reflux happens, and here I would say reflux again is a marker for a patient whose management is probably not optimal. You can see that once reflux happens, the probability of renal impairment goes up dramatically. Unfortunately, the surveillance of these patients is unsatisfactory, and once again, data from the US. So this is the National Spina Bifida Registry data showing that even in the US, when defined as one ultrasound scan and one creatinine estimation during 2 years, a significant proportion, almost 1/3 of patients did not really get the proper surveillance. And this, I'm sure, is a much bigger problem across the developing world. And one important thing that stood out in this paper when I read it was that the treating clinic remained an important factor in all sensitivity analysis and the multivariate analysis that was done. So the quality of the caregiver is very important rather than the facilities that you have. So the urological management of a patient with spina bifida must carry a sense of urgency, because even short periods of delay can lead to irreversible loss of function. And symptoms are a poor guide to lower tract dysfunction in such a setting. So in any high-risk neurogenic bladder, the ability of a patient to pass urine or to hold urine is not important. What's important is the bladder safe when it holds, and does the bladder empty in a safe manner? And urodynamics, as has been told by the two speakers before me, is a cornerstone for the assessment of these patients. So what are the management principles for spina bifida to try and prevent problems? Early initiation of conservative care. So this is exceedingly important. As I said, early assessment and early care. How early? As soon as practically feasible. So that might mean that you are assessing the child within weeks or days of birth. Now, you might ask me, can we get all information? Well, the answer is you can get almost invariably, you can get all this information regarding storage. And as Rizwan just told you very rightly, storage is what is critical in these patients. And you can assess storage in any child, any age. So early initiation of conservative measures, regular surveillance with urodynamics and renal ultrasound scanning is mandatory from infancy, but the timing is not well defined. Botulinum toxin therapy has been used, is standard for refractory neurogenic detrusor overactivity, but you don't have good quality evidence for this condition. And in any case, this is an expensive method of managing the patient. And there are certain other issues with using botulinum, which we will discuss when we are doing our panel discussion. So not probably so much for the developing world. Extensive surgery is reserved for failed conservative management, but very important to time this correctly. So if a child with spina bifida is not responding to your conservative measures and the storage pressures are high, it's almost like mathematics. This child with a high storage pressure is going to get into trouble, and you need to preemptively correct this problem if required, even by an augmentation cystoplasty. Now, I do want to make a mention about one point here before I conclude with my next slide about the storage pressure that Rizwan and Enrico talked about. And I just want to make a clarification here. The urodynamic finding of high storage pressures, and I'm not going to use that number which they've used, the urodynamic finding of high storage pressures can tell you if a bladder is unsafe. But the lack of high pressures on the urodynamics cannot tell you that the patient is safe. So you cannot use the urodynamics in isolation to take a decision about safety in an individual patient, which is a clinical decision based on overall assessment of the patient. Let's quickly look at some of the guidelines. You don't have a very good guideline specifically for spina bifida, and hence I had to go to this expert opinion consensus recommendations on spina bifida published recently. For the very young child below 1 year, an early ultrasound scan, serum creatinine and urodynamics to be repeated within 6 months. Initiate CIC and anti-muscarinics in the host-style bladder. Between 1 and 3 years, do regular ultrasound scans, as we just mentioned, on a 6-monthly basis. And then if there are any red flags in terms of urinary tract infections or so on, then urodynamics needs to be done or in between. Otherwise, annual urodynamics between 1 and 3 years of age. Thereafter, annual ultrasound scans and creatinine involve the child in the CIC process at an early age, and urodynamics whenever there's a red flag. And between 6 and 18 years, again, annual ultrasound scans and creatinine. Now, all this needs to be modified based on a whole lot of factors, and specifically, what were the initial findings like? And this can be, it can make a huge difference whether the initial management was started in time or not in time. So in children in whom the initial evaluation starts late, often poor compliance sets in, and you're in for a lifetime of problem. So what are the strategies to improve urological care? And this, I'm going to emphasize the 3 A's: awareness among the medical fraternity as well as the urologists, and a timely referral, access to urodynamics, to ultrasound scans. And we know that ultrasound scans, at least in India today, are easy and universally available across both rural and urban India. It is inexpensive, costing between $2 and $14, as we reported in our guideline statement document in 2019, and can almost invariably be scheduled same day across the country. You can have affordable care in our setting at about the equivalent of $25 a month, and this is how. A patient on CIC who reuses the catheter, which is the standard for all our patients, reuse. The difference in terms of patient outcomes between reuse and aseptic single-use catheters is very minimal. The community impact, the personal impact, the amount of waste generated by disposing is a different issue altogether. A set of 5 tubes costs less than $1, and all our patients are on a 5-tube technique, and they discard their 5 tubes at the end of a month. So it's $1 over a period of a month for a set of 5 tubes. A tube of Xalocan jelly costs about half $1 or so. And most patients are able to manage 3 or 4 catheterizations or 5 catheterizations with a tube with a bit of practice, obviously. The anti-muscarinics, again, in India are fairly cheap. You know that India is the pharmacy to the world, and solifenacin in India for a month would cost between $8 to $12, depending on whether you're using 5 milligrams or 10 milligrams. So it is possible to give a good quality care cheap in India, but I think our biggest challenge has been awareness of the medical fraternity. And hence, even now, 3 years ago, we surveyed our own data and found 51 patients with chronic kidney disease secondary to well-defined neurological condition affecting the lower tract in a 1-year time period, new patients 51. And if we included all the lower tract abnormalities, the number was 6 times higher. So it's very common, and it's a preventable double tragedy. So with this, I will go on to the case studies, the issues and discussions with a focus on safety. And I will now request our panelists to turn on their microphones and switch on their videos. I would also request all the audience that if you have any questions, please send them in. I will try my best to accommodate as many questions as we can. So as I said, we are going to be discussing certain issues, and the first set of things that we're going to discuss, Enrico and Rizwan, I hope you've got you're on the ball now. The baseline assessment is what we're going to discuss first. So very briefly, Rizwan, you've told a whole lot of things about the initial assessment, and I don't want to waste too much time on this, but just a little bit about what are the other things you look at, not just about the creatinine and the ultrasound scan, in terms of, let's say, patient social support, hand control, cognitive function. Can you just summarize the basic initial assessment of the neurogenic patient?
Very important, Sanjay, you have outlined it. In the history, you would generally either the neurologist or a rehabilitation consultant would have made the diagnosis. So we want to know in the history just a summary of the bladder function, but very importantly, bowel and sexual dysfunction on one hand, and on the other, which you highlighted, the hand function, the social support, and also their home environment. I think those are the key points to know, to formulate a reasonable plan for an individual patient.
Right. So clearly this itself is a huge subject, and many of the things we're going to discuss today are huge subjects on their own. But some of the basic non-invasive assessments are going to come out as we discuss. Enrico, when would you ordinarily plan your urodynamics in these, let's say, these two conditions, spina bifida and the spinal cord injury?
Yeah, first of all, I would like to tell you, as you know, Sanjay, that I'm a urologist involved in adult patients, not in children, actually. So I don't have much experience of directly of spina bifida patients when they're children, of course, because we have our pediatric urology in my city, where we refer those patients. But talking about the spinal cord injury patients, I think that it's important to make have the first initial urodynamics just after the shock phase. So as soon as possible after the shock phase, and then to follow up probably at 3 or 6 months to look for changes. We know that the shock phase may last for 1 month, but up to 10 or 12 months in some cases. But after this period, it's important to follow up the situation, to understand the pressures, to look at the pressures into the bladder, and to try to adapt your treatment to the single patients. For the spina bifida, as I told you, I don't have a direct experience, but I think that it is important to make the examination, as you showed in your slides, when the children are very, very small, and initially it's important in urodynamic investigation, but when they grow up, you may also consider other examination, not only the invasive test, the invasive urodynamic test, to follow up them.
Okay, Rizwan, I'm going to put this slide up for you now, and I've labeled most of the findings here for your convenience. The top line for all of you is the P-vesicle line on the urodynamics. The red is rectum, and the P-det is the third line here, which is the subtracted pressures. A quick word here for some of you. You can see the initial cough, the subtraction, the periodic coughs to see whether they subtract the cough at the end of the voiding phase and before the voiding phase. And you can see here that this patient shows phasic contractions. Now, Rizwan, quick comment. How would you approach this patient? So this patient has neurogenic detrusor overactivity incontinence.
First of all, we would like to know what is the level of injury. So if he's got NDO, by rights should have a suprasacral spinal cord injury. So that be the case, NDO, with NDO incontinence, although it's incontinence, but it makes me feel a bit better because that means that the pressure will not remain in the bladder. When it's goes above a certain value, it's going to leak. But having said that, if this gentleman or lady is on anti-muscarinics, then I would move to the next step, which is the botulinum toxin. But
so this is first
see at the
first
you see in the voiding phase is not is acontractile. So what we want to do is to, in neurogenic bladder, we need to dissociate the filling phase from the voiding phase. So here the problem is both in the filling and the voiding phase. For the voiding phase, to be honest, for neurourology, we've got only one option, which is a catheterization, be it intermittent or be it permanent. So that is for the voiding phase. For the filling phase, with medication first, and then botulinum toxin, and then obviously cystoplasty.
What would be your choice, Rizwan, of medication? What would you use?
This is my personal, I have stopped using oxybutynin because of the risk of cognitive impairment. I know there's a lot of controversy. And of all, when I ask a patient, most of them will, I have not gave anybody oxybutynin, but I used to be asked this question, have you ever tried it yourself? Oxybutynin is a horrible medication, very effective. I will start them now either on solifenacin or preferably I've started to use mirabegron more and more. And there's a lot of evidence now coming out that it is as good in neurogenic, if not as anti-muscarinics.
As of now, your own guideline, which you're a panel committee and member of, doesn't recommend it, does it?
It does not. Hopefully next time it will be, because it waits for the randomized trials. But otherwise, that's why I said that I didn't say guidelines, I said publications are coming out which says that it is. Yes.
I have a question for maybe you as well as, or maybe Enrico, one of you can take it. How well do you think does mirabegron get the pressures down? So I'm not talking about the symptom of incontinence. I'm talking of the storage pressure in terms of safety. Now, do you believe that mirabegron is as good at taking care of the pressure?
Of the two studies I know, I can't remember on the top of my head whether they checked the urodynamic parameters also. They were symptomatic ones. So I can't remember a study. I think there was one which was done, but I'm not sure whether they looked at the urodynamics also bringing it down.
So I think here, especially when we talk of high, sorry, Enrico, go ahead. Yeah.
No, just to try to reply to your question. I think that the balance between the muscarinic stimulation and norepinephrine stimulation of the bladder is a balance. So increasing, let's say, the norepinephrine stimulation with the beta-3 agonist may in a way improve the compliance of the bladder, improve the stretching, let's say, of the bladder, reducing in this way the pressure. This is my actual explanation of I don't have a better one.
Rizwan, how would you assess your patient? You've started this patient, let's say, on solifenacin 5 milligrams. I presume that's what you would start with. And this patient is on intermittent catheterization. So what do you do now? I mean, when do you ask the patient to come back? How do you assess your patient?
Like most thing in life, the truth lies somewhere in the middle between the ideal, what you want to do, and practically what you end up doing, if one be honest. So what should happen in the ideal world is, if the pressures were high, and I started somebody on an intervention, be it medications, be it botulinum toxin, then within the 3 months interval, I need to repeat the same investigation to make sure that I've achieved my objective, and then I can, follow them up kind of indefinitely. In practice, I think what most of us end up doing is, if they are symptomatically better, then that investigation is pushed back on the shall we say, government sector for 6 to 9 months, but obviously somebody's the difference between the public and the private sector. But that is what ideally should happen. Evaluation in 3 months, achieve the objective, then it can be symptomatic-led.
Okay. So when you call your patient for evaluation, what are you looking at? Enrico, for instance, we always insist on IC diaries, and I'm sure that your patients would also carry them. We give them a small booklet and ask them to make a record for at least 2 to 3 days before they come back to us. So how, Enrico, do you use that diary record, practically speaking?
Yeah, it is very important, as you mentioned. The diary are mandatory. I mean, I just would like to underline that, for instance, even to make to decide the speed of the filling of the bladder filling during urodynamic test, you should have the urodynamic diaries, because you should know what presumably the capacity of the bladder is. So in case of a reduced capacity, you should reduce the bladder filling during urodynamic test. So it's very important also for technical aspects. But I think that it's important for patients in undergoing intermittent catheterizations. For instance, it's important the volume of the urine they take out with the catheter each time. It's important to avoid sort of distension of the bladder. So and in case I mean there may be patients who drink too much. So in case you find a polyuria, it's important to suggest to the patient to reduce a little bit the income of liquids during the day. So I mean, basically have a lot of information from these diaries that you should use in the counseling.
If the patient hasn't responded to the medication that you have prescribed, it can give you some clue as to whether the problem lies with the patient's fluid balance or not, and so on. So it can help take decisions regarding that. Now, we just discussed about video urodynamics as being mandatory at the first evaluation. Would you believe that this patient will require a video urodynamics, Rizwan?
Like I said, I am a firm believer in video urodynamics, and that's why I put up that
fair enough.
That slide also. At least at the first evaluation for a neurogenic patient, you can pick up the general outline. We say with the video you see, with the non-video you don't see. And it's a matter of prioritizing. So if you do video for everyone in the first, then a lot can have follow-up with the non-video later on. And so I will do video for the first, both spina bifida and spinal cord injury for the first one. Follow-up can be non-video.
What about if this patient presents with renal insufficiency at the outset? So patient has got bilateral, it's not at all uncommon in our setting. The patient comes for the first time, has got bilateral hydronephrosis and an element of renal insufficiency.
I think, Sanjay, it is very important. And one of my teachers, like yourself, I've been blessed with a lot of very good teachers. One of them was Professor Christopher Woodhouse. Some of you might know him. And he said, in these cases, always go from down up, which is actually for the non-neurogenic patients also. So this is a patient, spina bifida patient, generally a spinal cord presents with bilateral hydronephrosis, maybe kidney function is off. You're not sure about, even they might be self-catheterizing. The first thing one needs to do, like a high pressure chronic retention, is put a catheter in and see whether it drains. Now, the reason for that is then you disassociate between the infravesical obstruction and the ureteric, neurogenic, non-neurogenic both. So once you put the catheter in,
we need to move on, right?
Okay.
So
yeah, exactly. So
we'll
do that.
Yeah, so good point. So good point that we need to put in a catheter first. That's the quickest way of normalizing renal function.
And finding out whether it's the ureters are nipped off or it's a DST.
So this is that same patient and a video study on the same patient. And you can see here that the patient had a spine fixation. You can also look at reflux happening into the kidney.
You can.
Let's come down and see here. Now, this is one of the points at which this patient, you can see, had a phasic contraction and a leak happening here. And you can see some dilatation of the prostatic urethra and a reflux happening in the same patient. All this would be missed in the patient had we not done a video, that this patient actually has dyssynergia and reflux. And not all patients with reflux will show initially at least hydronephrosis.
And especially, Sanjay, if I can add, the most important aspect of the video is that you can couple, you can put together the information of the video with the information of urodynamics, because you could do the two examination independently, but you would miss the simultaneity of for instance, the increase of the pressure and the appearing of the reflux. So in this case, we call this an active reflux. So this is the only way to assess this kind of finding is the video urodynamics. You cannot use the cystometrogram together with radiology. I mean, the urodynamics together with radiology to have the same results.
We'll come to that, whether you can combine them or not.
Sorry.
But that's fine. But you can see the ground reality, Rizwan, Enrico, is different. The ground reality shows, look at this from 2008 from Holland, from 2006 from Canada. I'm sure things might have changed a little, but they might not have changed all that much. And the fact is that even in the Western world, video urodynamics is not routinely offered to all these patients. So although it's ideal, but I think, let alone in the developing world, even in the so-called first world, this remains a utopian goal which is not yet achieved. I'll just quickly run through some of the anti-muscarinic guidelines recommendations. Use anti-muscarinics for neurogenic dysfunction activity. That's universally by all the guidelines. This is from EAU 2020 with a level of evidence 1B, Rizwan specifically. Your guideline, you're an author to this. Mirabegron does not improve urodynamic outcomes in neurogenic bladder. This might change, as Rizwan said, but we will wait for it to change before we include it in our recommendations today. The guidelines do not make a recommendation with regard to poor compliance, incidentally, and we find a fair number of patients coming to us with poor compliance because we know if the intermittent catheterization is not started early, then many of these patients will develop poor compliance. Let's look at another case here now. A 31-year-old male with a history of anorectal malformation, denies major voiding difficulty, has episodes of urgency and urgency incontinence, which brought him to the hospital, 1 to 2 episodes of febrile illness in a year, has constipation, but is able to, inverted commas, manage, and is ambulatory, normal upper limb function, a keen intellect. And this is his urodynamics. Again, now let me label this. The top line is P vesicle, third line is P dead. The capacity is about 320 ml. The compliance looks normal. There's no neurogenic detrusor activity. There's some spontaneous rectal activity. The end-fill pressures look okay. And this patient is again acontractile. And so I'm now going to ask Rizwan. Rizwan, is spontaneous voiding okay for a patient like this?
Probably not, because at the moment it appears it's all right. But one of the reasons of him having frequency urgency is probably, although you say no PVR here, but it might not be emptying and might be leading to that those symptoms. So I think a frequency volume chart is very important. Sometimes what I do in patients like this is that teach them the art of intermittent catheterization, get them to do catheterize first thing in the morning, last thing at night, and in between they can, void within inverted commas.
We'll move on, Rizwan. Yeah. Okay. So your point well taken that you are not happy in allowing this patient to void. And yes. I completely agree with you, because this information I have given you is not enough. I haven't given you a whole lot of things that I should have. So this child, if this patient actually has a creatinine of 5 milligrams at this point when he has come for the first time, has bilateral hydronephrosis, but no PVR. So you can see a good capacity, no PVR is no proof that the child is going to be safe. And you can see again, this is this patient's, this is this patient's video. And let me quickly run the video here, and you can see that this
they might be having reflux.
It has reflux, large volume reflux.
Exactly, that's what my point was. So that is taking the upper tracts are working as a pop-off valve.
And when he tries abdominal strain voiding by Valsalva, there's a gross dilatation of the prostatic urethra because the pelvic floor doesn't relax. So it just goes to show that this is not at all a safe situation, a very, very misleading plain urodynamics, a completely different picture on the video. So crucial lessons, patients with high risk neurological diagnosis must have urodynamics, should be combined with contrast imaging, ideally video, but the EAU 2020 and Canadian Guidelines 2019 says that it's acceptable to combine a VCUG with the urodynamics if you don't have the facility. Ability to void is not important. Storage pressures are not enough for making decisions regarding safety, but they might be enough to take decisions regarding a lack of safety, as I said. We will talk a little bit now about some of the other aspects of initiating therapy. We are running short on time, so I need to speed this up. So In some situations, spontaneous voiding might be adequate. And I will ask in case you would differ or would like to add anything to this list. The patient should not be having DSD, should not trigger autonomic dysreflexia, should have safe evacuation pressures demonstrated on urodynamics, should be able to empty adequately, do not develop recurrent infections, hydronephrosis, and needs to be monitored carefully. If all these can be fulfilled, some of your patients might be able to manage with partial or complete spontaneous voids. I will skip this for want of time, I think, and go to the subsequent therapy on botulinum. So I'm now going to ask you, is continence after botulinum enough to decide that the botulinum worked? Rizwan, we need quick answers. So
Well,
do you think—
it's just where we have started off from. If the problem was low pressure and incontinence, then yes. If it was for high pressures, then you need to actually, continence is not enough because it can be counterproductive.
So Enrico, after giving botulinum, would you, so we are talking post-botulinum. So if you've given botulinum, Enrico, do you ordinarily check on the urodynamics after the botulinum in these patients?
Yes, our usual behavior is to check urodynamically after the first injection of botulinum. If we find a good, let's say, result, so lowering of the pressure that we consider safe, then for the next botulinum injections, we don't usually repeat the urodynamic investigation. But for the first case, first treatment, yes, we always do the urodynamic test, invasive urodynamic test.
So I completely agree with it. The only thing I want to add is that you only repeat it once after 5-6 injections, it stops working, then you see why it is.
Yeah, of course. But in case of, I mean, of any changes in the clinic,
very correct.
Of course, we do it. Yeah.
Is long-term discontinuation of botulinum an important issue for you?
In the setting of neurogenic patients, you mean?
Yeah. Yeah.
I think it is. I mean, I don't know why, but we have we lose some patients in the follow-up. Sometimes we don't know exactly what happens to those patients. So I think it's an important. Also, if you look to the literature as you are doing now, we know that some patients discontinue the treatment. The adherence is not ideal as we may think. I mean, about those patients.
For us, I think an important reason not in this list is cost, because botulinum is expensive. But some of the other reasons are listed here from the study, which is an international study from the Western world. Failure, patient decision, non-improvement, neurological progression, and an adverse event.
Can I say something, Sanjay? Not in Italy, actually, because in Italy, this is done for free in the national health system. But so the cost is not an issue. But for me, the setting where you perform the treatment is important for the patients. In some centers in Italy, it is performed in the ward. I mean, so we have to stay 1 or 2 days into the hospital to perform botulinum toxin. In other centers, it is performed as an office procedure. And I think that the less invasive, let's say, in terms of presence in the hospital for the patients, the sooner we send back to home our patients, the more acceptable is the treatment is for those patients. So I think this may be another reason.
Sanjay, I just want to add to this very quickly is that it is the responsiveness of the treatment is also. But in the UK, we have got the NHS, and the attrition rate is more because you cannot guarantee them coming at 6 months and they get frustrated. On the private sector, it is not, because if you have the responsive treatment, they know it's going to get, those are the ones who are compliant.
And this slide alludes to the issue that Rizwan was talking about the long-term failure, that some patients tend, start developing long-term failure. So obviously we need to be aware of the red flags to be able to identify patients for further evaluation and to be able to take them off the treatment, or to see whether we can do something else in terms of managing them. Now, one of the problems has been that there is no clear demonstration that botulinum improves the safety of an unsafe lower tract. So if a patient has demonstrated a clear unsafe lower tract with upper tract dilatation, for instance, hydronephrosis already developed, would you be comfortable managing that patient with botulinum? The patient already has hydronephrosis of the upper tracts. This one?
I am very uncomfortable once you have demonstrated the upper tract dysfunction and renal impairment also. I will try to persuade patients to go down the path of cystoplasty. But again, during that time, you can try botulinum just to see if the pressures can come down. But in the long term, it is very difficult to maintain them on that. And one should err towards the cystoplasty.
You're always worried about a lifetime exposure to higher pressures in patients who've got a bad bladder. Okay, let me skip some of these things. What about the patients who have to take a lifelong of anti-muscarinics? We know it's never going to stop. And the cognitive dysfunction in these patients who are children, they'll grow up adults or elderly and so on. So is that a concern? Would a patient, if a patient comes and tells you, I don't want the anti-muscarinics, inject me with botulinum, I'm fine with that, what would be your answer, Rizwan?
To be honest, I am perfectly all right with that, because like I said, these are the patients who are young patients, even 30s, 40s, and they have to take these medications for 30, 40, 50 years. I think not, and also we are talking about cognition and bladder, but it affects their bowels also. So I am actually very comfortable, and if they want to go stop the medications, want to go botulinum toxin, or even we can discuss sacral neuromodulation also, I'm comfortable with that.
Enrico, do you offer your patients an option of botulinum ahead of anti-muscarinics ever?
No, not really.
Not
I don't, but I'm just trying to understand.
Not ahead.
Not ahead. It's not the standard, at least. But I agree with Rizwan. But that, I mean, in a way, it's something that may be less risky for the in the long term. But you usually start always with antimuscarinics. Right. And actually, in my experience, I mean, I follow up patients now since 25 years, probably. I haven't seen that many with, I mean, showing dementia problems during time, actually. But they are still young patients because they started when they were, I don't know, 20 or 25 or 30. So probably we need more time to follow up those patients to see this kind of complications. Okay, so I think that oxybutynin, as Rizwan said, is probably the most dangerous drug we can use in that sense.
Rizwan, about augmentation. Now, augmentation, we know there's a lot of improvement in technologies. You can do the augmentation robotically. In these days, skilled surgeons are able to do that. The issue with the augmentation is really not so much about the peri-op complications. My problem with the augmentation is with the long-term problems. And in our experience, I've had only 2 patients who have perforated in the long term. One perforated and came to us in about a day's 24 hours after the perforation. And one presented to a different center, and we lost both of them. Despite all, I mean, the patient who came to our center, we had the patient on the operating room table in 90 minutes from the time the patient presented. And we still lost that patient. He had certain other diabetic and so on. But it's an imperfect solution, isn't it? What proportion of your patients land up with augmentation?
Interestingly, after botulinum toxin, much less. In the UK, we were doing close to about, I think, 200 augmentations before botulinum toxin, and now they're down to, I think, 20 or 30 a year. So they have come down by 80, 90%. But having said that, there's a proportion of patients in whom it works very well. They just need to be followed up. It's a lifelong commitment. You need to follow them up regularly. If you follow them up, by and large, they're all right. Infections, mucus productions. There are 2 main things which
are wonderful. The procedure works like magic. Yeah. It works like magic, but comes at a metabolic cost and the odd perforation. And that perforation is really has me really scratching my head, because it comes out of the blue. So I'm talking of 2 patients out of about 140 or so that we've augmented, and 2 perforations lost 2 on 2. So really, it's a concern because it just happens, augmentation without any premonition, nothing. Patient has been on CIC for years and suddenly perforates. Anyway, so as you said, a considered decision whether to augment or not. So we need to quickly wind up. So I need to tell the red flags which we have alluded to repeatedly today. And so perhaps maybe I will ask one of you to discuss this very briefly. Enrico, would you like to just mention about these red flags? Anything that stands out for you?
Yeah, no, I think this is a very good, let's say, summary of what we should look for in our patients as a red flag to investigate more carefully and to follow up more carefully those patients. I think, I mean, I have nothing to add particularly.
Okay, so there was a question from Dr. Manish as to whether we can manage patients without urodynamics. So let's say you don't have access to urodynamics. Is it possible to manage them? Very quick answer. There were a couple of people who raised their hands, but they've not sent in questions. So if you have
of course it is. You cannot ignore the patient. You just follow them more closely with biochemical tests and ultrasound scan and make sure as long as they're all right, the scans are fine and blood is all right, no infections, then you can. So it is not mandatory. I mean, it's mandatory, but you can always do that. One thing, and in that patient, and in the red flags you said, it is very important. The change is very important. So somebody is all right for 20 years and suddenly start to have recurrent infections. All of us have seen that when you do a cystoscopy, they might have cancer. So it is the change which is important rather than per se the system it is.
So aggressive use of ultrasound scans, creatinine estimation, of course, is a very blunt tool, but I think the ultrasound is quite sensitive for picking up a problem in the upper tracts before a problem really becomes bad.
Also the shape of the bladder, I mean, is important, I think, because when you follow up those patients, you can see changes in the I mean, of course, the verticula, but also changing in let's say in the shape in the bladder, also wall, I mean, thickness. It's important to investigate this aspect also.
Sanjay, we have got this supermarket in the UK, it says Tesco's, and underneath it is every little helps. So history, creatinine, ultrasound scan, features, everything. So every little piece together.
Great. Yeah.
Sanjay, could I butt in here for a while?
Yes. Oh, yes. We're about to wind up anyway. I was looking for you.
See the wonderful discourse on a great update. Thank you, all three of you. But the question which touches me particularly from Indian context is still, I'm not talking on the basis of data, but impression. 70% of the patients are not in the hands of experts like you, Enrico and Rizwan. And there's a ground reality. I always found a disconnect between the neurosurgeon's approach to meningomyelocele surgery, and most of the time it is the conscientious parents who bring them to the urologist for management. My question is that since it is being managed by general physicians, general surgeons, I would like the panel to emphasize on the importance of clinical examination. And in my practice, I found rectal examination in these patients, particularly the subtle ones, where there is no obvious cause of spinal cord injury or spina bifida. I have seen incomplete spina bifida where the person at the age of 34 did not know that he has a sign of spina bifida and presented as outlet obstruction. Similarly, somewhere we reported 6 patients of sacral laziness is diagnosed on rectal examination. Sphincteric patterns and kind of bladder, I think it still, I feel, gives a tremendous information as far as so I think this is understood for a specialist group, for a general physician or somebody to take as a red herring if you think you can really re-emphasize this fact.
Yeah, I couldn't agree with you more, sir, that I think increasing awareness amongst the non-urologists who are actually managing these patients as the first line of management is so important. The pediatric surgeons, the neurosurgeons, the orthopedicians, anybody touching the spine, or anybody managing anorectal malformation for that matter. And many of these patients are with these primary specialists for a substantial period of time and still develop a problem of the kidneys, which is really a shame. It shouldn't happen. So we need to do a better job in getting our point across to all these other specialties. It's already happened well in the developed world, I think, but in the developing countries, this is still an issue and we still continue to face this challenge. So the Urological Society of India has actually done programs. We've done programs for other specialties also, in terms of teaching them the basics of neurogenic lower tract dysfunction. So I think you make a very good point there, sir.
Absolutely, and we can add to that the patients with multiple sclerosis. They are seeing the neurologist, like you said, for 10, 15 years incontinent infections and not refer to even a continence advisor, but talk of a neurourologist.
So it was interesting that Dr. Manish asked about that managing patients without the urodynamics, because Professor Bhandari actually in the beginning of his career, and in fact, you don't know Professor Bhandari, but I in the beginning of my career also used that manometry with a central line and a connection to the bladder to kind of get static pressure measurements with a three-way stopcock to measure the pressures in the bladder without a urodynamics machine. So I guess it is possible to improvise and manage your patient, and perhaps at least make sure that the patient doesn't develop renal failure because of the lower tract if you're conscientious, even if you don't have the urodynamics. I think it's possible.
If I have a word of advice for ICC, I think they, at one end, they have to explore the depths on the subject, but they should focus on this majority of patients who are still suffering in the hands of mediocre or ill-informed people. And if I look at critically the inferences drawn from water manometer or clinical examination, I still feel we had seen that we had Euro video 5500 first time from Danitech, which Sanjay worked on. And now there should be a lot of simplified versions. I still feel the qualitative information of urodynamic out study is much more valuable than I'm talking of a commoner, which gives you a pattern of neurogenic bladder is very important. I have one more question from my side, a curiosity. Would the panel like to comment? According to me, though the spinal shock state of neurogenic bladder, which is a lower motor neuron pattern or whatever you call a flaccid pattern, is taken as innocuous stage, but according to me, that stage management in that critical window, particularly when they come out of the shock and start showing the pattern, I think to my mind, the clock sets there on the deterioration of upper tracts. And as very rightly pointed by the panelists, once there is a dilatation of upper tract, I think the management becomes much more challenging, outcomes more uncertain. Literally, you are on a downward escalator.
I think you are spot on, and there's a lot of now research going on to see if during that early phase we can do something so that the NDO is not established. And I think like K.D. Seaver did this experiment with the bilateral sacral nerve stimulation and showed that if you do it very early on when they are in spinal shock, they never develop overactivity. There's some research going on that if at the cellular level, that if you do that, then the formation of these P2X receptors upgradation or upregulation does not happen. So you are very right. I think that is the area of focus. Once the insult of spinal cord injury has happened, what we can do to make sure that it does not progress to an unsafe bladder, and that is very critical time.
So I think I will wind up this panel discussion by the take-home messages which I have put up here regarding spina bifida, spinal cord injury, and anorectal malformation being high-risk neurogenic bladder diagnoses. But unfavorable features and clinical or invasive testing can identify other high-risk patients who don't have these particular diagnoses. Storage function is crucial but often neglected. No single method of evaluation can determine safety, although a single method of evaluation can tell you lack of safety. Patients need lifelong surveillance with additional invasive testing triggered by red flags. I must thank the Vattikuti Foundation as well as ICS for having engaged through me with each other as well as with the audience for this program. And of course, Professor Bhandari, really, you have been an inspiration for me, and thank you so much for involving me. Enrico, Rizwan, thank you so much. I will now hand it first to Enrico and Rizwan. They will do an informal chat for a minute on the ICS, and then it's to Dr. Bhandari to wind the program up. Thank you all very much.
Thank you very much. I'll just take half a minute to actually echo what Professor Bhandari was saying, that we at ICS are passionate about neurourology. And I've now become the chairman of the Neurology Promotion Committee, and I'm very passionate. And Sanjay has been instrumental in helping to make this global teaching program. And Professor Bhandari will be very happy to know that this is what we are trying to do through this program of ICS and Neurourology Promotion Committee, to have these workshops all over the world, engaging the physicians, not the specialists, but the physicians who actually look after these patients. We have these webinars and teaching to see how a safe bladder, neurogenic bladder management can be established according to the local needs. So we'll keep on posting our information, and I hope that we'll have more interactions with you and other organizations. So thank you very much on behalf of the Neurourology Promotion Committee of the ICS to involve us with the Vattikuti Foundation. Thank you very much. Over to Enrico. Thank you.
While thanking you and Sanjay and Professor Enrico, I must extend and continuing, iron is hot, so I must extend a continuous invitation to ICS. Sometime in future, we should organize a webinar for patients. My job is post office, they keep on contacted me. They don't know where to go. And there are very few Sanjays in India where I can think of. Otherwise, neurogenic bladder and strictured urethra continues to be the waste paper basket for urologists. I can add chronic prostatitis to that, because they are not their choices. They are not the excitements of procedure. So I feel still there is a good educated class of these patients or parents. They are groping in the dark. They don't know what more they can do for this child besides making him socially acceptable. So I would recommend, think about how can we really plan an absolute low-level program to tell what a patient can do in order to get the best outcome. Because you will agree with me, whenever we are talking of such long-term maladies, or what you call the infirmities, it's always patient and family's cooperation decides the outcome. You will do your best only if he comes to you in the clinic. But if he doesn't know anything else can be done, because most of the time is gloom around. I was talking to some investor who was working and asked me, where could he really invest his money for the best?
I apologize. We seem to have lost Dr. Bhandari's audio.
And they were surgeon in. Hello. Can you hear me now?
We hear you again.
So what I was telling, and he said that, well, what more you can do? Anyway, this guy is paralyzed. Nothing more can be done. Why waste money on that area? So I think there is a lot of unawareness, even in literates about this. A lot can be done, because when I see these patients in United States driving and doing everything, and they have all the privileges. My cousin, he came to Chicago to receive me. He was right at the tarmac to receive. This is pre-9/11 time, and he had all the privileges of just down the elevator path. And he was an activist. He would say that this hotel is not made according to the guidelines. He will immediately call the police for all those things. So I think those rights, India, you will agree, Sanjay, are totally not known. And I would really emphasize that we should focus. A group of you must focus on educated patient and families, and training the portals of entry, which may be neurosurgeons or anything, because it's so important if you focus from the point of view of patients. So I think we can go on, but I will give back to Sanjay to wind up, and then Dave to.
Enrico, I think you have a slide to show. Enrico, you wanted to show a slide quickly.
Yes, I would like to
yeah, don't worry, because we are retaining audience for a long time, and
almost done. He just had a slide to show about the ICS.
Exactly, and I would like to say that ICS is very also important for patients. So there is a cooperation with the patients associations around the world, and the ICS is providing information also to patients. So I agree with Professor Bandari. This is crucial. Just very briefly, just to say that members of the ICS have some privileges, for instance, the subscription to Neurology and Urodynamics journal. There is an exclusive access to ICS live events and online content. The website of the ICS is very comprehensive, and there are now a lot of contents on the website that can be accessed by members. The cost to subscribe to the ICS is £70 per year, but I can tell you that there is a special discount, let's say, for the Vattikuti Foundation delegates, that is £10, so only £60 this year for using the promo code ICS Vattikuti for those who were attending this webinar today. Just to give you some examples, the ICS Standards is a book, a very comprehensive book with the probably the most important papers in the field of continence published in the last years. So there are papers on terminology, on standards, on urodynamics, good urodynamic practice, all together in this book for free for ICS members. Another very important feature is the glossary that can be also available on the mobile phone to use the correct terminology and to understand the correct terminology used by the ICS. These are just two examples of what you can obtain being an ICS member. And just to finish, I would like to invite all the attendees to send their abstracts for the ICS online. ICS will be online also this year due to the pandemic situation. It was planned to be in Australia this year, the meeting, but it will be online also for 2021 from 12 to 15 of October. But we have time until the 4th of May, the 4th, actually, to send abstracts for the ICS. So I would like to invite all of you to send abstracts for the ICS meeting. And with this, I finished. I would like to again thank the Vattikuti Foundation for inviting us, for inviting me and Rizwan and the ICS and Sanjay, of course, for this invitation and for working together today. It was really a pleasure.
Thank you. Enjoy your evening, everybody. And we look forward to being with all of you sometime soon with another program. Okay. Last words, Mr. Bandari?
Thank you very much.
Dave.
Thank you.
Thank you.
Gentlemen, thank you so much for sharing your insight today. It was really wonderful to see the care that you have for these special needs patients. I had no idea of, the work that you're doing, and I learned a lot today. Here's a quick look at our website, and the video will be up shortly next week, and it'll appear in the very first box. This is our most recent program. So with that, I'm going to say good evening, good morning, good afternoon. Thank you, gentlemen, so much for taking time out of your busy schedules to be here and providing a very informative program today.